is going to be immunocompromised to a degree. So attention to nutrition, absolutely vital. Alcoholics are more prone to pneumonia, don't know why, but they are. And smokers are more prone to getting pneumonia. And here I certainly do know why. The main reason here is that smoking paralyses the cilia, which normally waft the secretions up into the trachea where they can be coughed up. Wafts them up. And instead of wafting when people smoke, the cilia stop. Smoking paralyses the cilia. Therefore, there is stasis of secretions. Because there is stasis, there's an increased likelihood of infection. In fact, this is why smokers cough first thing in the morning. All throughout the day when they're smoking away, the cilia are paralysed. It's only when they go to bed at night and they have a few hours without smoking that the cilia start working again and start wafting again. So they start wafting in the night. And that means by the time the smoker wakes up in the morning and the cilia have been wafting all the accumulated secretions of the day before into the trachea, they have to cough it all out in the mornings. It doesn't work as efficiently. So smoking paralyses cilia, therefore promotes stasis, therefore promotes infection. So very important not to smoke cigarettes or any form of tobacco. In fact, don't smoke anything, come to that. So, smoking. Cold weather. In individuals prone to this, particularly those with chronic bronchitis. Again, it seems to lead to more infections, and it also paralyses or reduces the activity of the cilia. The cilia don't like being cold. Overcrowding. People that live in poor, overcrowded conditions. They're breathing in each other's humid air, which is, and the bacteria cling to the droplets in a person's exhaled air. So not only is the air quality lower, but there's a greater amount of inhaled bacteria from other people's air. So in conditions where there's overcrowding, ventilation is absolutely crucial. Hot, dry indoor air. Here the dry air seems to dry the secretions, and if the secretions are dry, they're more viscous and they don't clear properly. And of course, air pollution has all sorts of nasty effects on the respiratory tract. So people that live in polluted cities are more prone to pneumonia than people that live in nice, clean air in the countryside. So quite a few factors there to consider in general about the prevention of pneumonia. The main thing, as you've probably gathered, is keep the individual healthy, and their own immune system should keep them healthy. People tend to work well when they're properly looked after. Not always true, but usually true. Now let's think about the way we can prevent pneumonia specifically in our patients as nurses. The nursing prevention of pneumonia. Key thing here is to mobilise patients wherever possible. Patients should only be immobile if there is a specific reason for them to be immobile. Now it might seem cruel getting someone up the first day after they've had an operation, but if at all possible, it's very important that we do this. So mobilise patients whenever possible, only nurse them immobilised if there's a very good reason to do so. And if a patient must be in bed, then nurse them upright, prop them upright. When they're upright, they'll be able to breathe more easily and clear their secretions more easily. Avoid tight bandages and clothes that restrict normal chest movements. And prevent dehydration. This is very important. The patient's dehydrated, the secretions will become dehydrated, therefore they will become thicker, therefore they won't be cleared as easily as they would be if they were fluid. So prevent dehydration to prevent the secretions from becoming thick and dehydrated themselves. If the patient is well hydrated, their secretions will remain fluid and be much easier to cough up. Therefore stasis and subsequent infection will be prevented. So fluids prevent dehydration. Deep breathing will encourage expectoration of mucus from the lungs. And of course, coughing will cough up material from the bronchioles and the trachea, which can be then swallowed or spat out. The main thing is out of the lungs and not causing the stasis anymore. Of course, we advise our patients not to smoke, and physiotherapy in patients that need it. Now, one of the main things here, in fact, we carry this out as nurses, of course, is that patients' positions must be changed very regularly. If a patient has a stroke or something and is immobilised, then you must change them from one side to the other regularly. This will also prevent pressure sores, of course, but it will help to keep the lung clear. And absolutely essential they have some time propped up, if at all possible. But physiotherapists can do other things like shake the chest or even pummel the chest to mobilise secretions. Patients that are unconscious and intubated, in fact, may even be sucked out using suction equipment if that facility is available. And in patients that are immunosuppressed or at particular risk, antibiotic prophylaxis could be considered. So we've thought about general preventative measures and things we can do specifically to at-risk patients as nurses to make pneumonia less likely. The next thing I want to consider is what observations do we make as nurses on patients who have pneumonia? What are we looking for? And indeed, why does it matter? So, general observations in pneumonia. Well, of course, we do temperature, pulse and blood pressure. Temperature, we've said, may be raised. Pulse will probably be raised. Respiration's very likely to be raised. Blood pressure may be raised if the patient's distressed. But importantly, if the patient is becoming shocked due to septicemia, then the blood pressure will start to fall. So monitoring the heart rate. If the tachycardia becomes more severe, this may indicate increasing hypoxia, and the heart is attempting to compensate for this by increasing cardiac output. But of course, we want to, as with everything, we want to follow the general progress of the condition. Is it okay? Is it getting better? Is it getting worse? So progress or resolution of the condition. How is the condition evolving? And crucially, how is it responding to treatment? So spread of the infection, as we've said, may occur particularly in staphylococcal pneumonia, and shock due to bacteremia and possible septicemia is not impossible. And of course, in shock, the blood pressure will fall. Shock is a state of acute hypotension. And although we might not listen to the chest with a stethoscope for diagnostic reasons, it is useful to practice listening to the patient's breathing sounds and seeing if they're getting better or worse, or indeed where the sounds are clearer and where they're not so good. So listen to the patient's breathing sounds. Now this of course can inform treatment as well as physiotherapy. We can observe the chest movements and see if they're symmetrical. If they're asymmetrical, that may indicate a lobal pneumonia or a localized segmental type pneumonia. And as well as, of course, the symmetricalness of chest movements, the degree of chest movements can be observed. We can listen again with a stethoscope for areas of reduced or absent air entry. And of course, we want to look at the main thing is to look in the patient's face. What's their general condition? Colour, are they pallor? Is there a pallor? Are they cyanosed? Are they pale? Are they cyanosed? And a key observation, type and volume of sputum. And of course, we'll have sent sputum off for culture and sensitivity, or if that's not available, direct microscopy to look for the etiological organism. So type of sputum, as we've said, if it's rusty, it may be pneumococcal. It will tend to be purulent, greeny, thick, yellow, horrible, infected, possibly pussy, possibly blood-streaked. All these things can be relevant and we should observe these and record them. and the volume of sputum. Fluid balance chart should be maintained to make sure the patient's got an adequate fluid intake. And of course, if the patient is suffering from developing cerebral hypoxia, then there could be disorientation or reduced levels of consciousness. Blood tests may be carried out. So you would normally expect white blood cell count to be raised, ESR, erythrocyte sedimentation rate to be raised, and typically you get a polymorphonuclear leukocytosis, lots of polymorphs. The granulocytic neutrophils would be, the count of those would be very raised, as you would expect with infection, because it's the neutrophils that combat the infection primarily. And of course, chest X-ray could be performed to give more information about the patient's lung condition. Okay, so there's some of the things that we can look for in the patient with pneumonia and why we're looking for them. Let's now go on and think about management interventions, things we can actually do to help the patient who is suffering from pneumonia. So, the management of pneumonia. And of course, the aim is that the condition will get better, that the inflammatory fluids which are causing the consolidation will be reabsorbed or coughed up, and lung function will be restored, and the infection will be resolved. And of course, to do that, we're going to need to kill the infectious agent, which we'll come on to in a minute. Now, without antibiotic treatment, pneumonia can resolve, but the mortality can be significant. So what I want to do now is break the management down into various sections. And the first section we're going to look at is prevention of spread of the condition. Now, one thing we want to do is prevent the condition spreading to other people. Now, most types of pneumonia wouldn't be that contagious if the person was fit. But if a person had pneumonia, you certainly wouldn't put them in a bed next to someone who was immunocompromised for whatever reason. Because these things are droplet infections. The air, the water vapour that a person breathes out, the bacteria sit on those droplets of water vapour. It's droplet infection. So one thing we need to be very careful with is safe disposal of infected sputum. And barrier nursing is not normal in pneumonia, but there are some types of pneumonia which are more infectious. For example, to take the most extreme type, there is a type of pneumonic plague which is closely related to the bubonic plague, the Yersinia pestis organism, causing pneumonic plague, remarkably contagious. It is a plague, in fact. So, depends on the etiological organism, but normally it's not too infectious to people who are otherwise healthy. Now, of course, we want to treat the infection, but there's a way to do this. So when pneumonia is suspected, if at all possible, get a sputum specimen. And this isn't always easy because in the initial stages of the condition, the cough tends to be unproductive. But if you possibly can, get a sputum specimen before you start treating it. So get some sort of specimen for culture before you give the first dose of antibiotics. That means you can then culture it with no antibiotics clouding the picture and then give the specific antibacterial therapy for that condition. So a sputum first, if at all possible, then give a broad spectrum antibiotic straight away. We don't wait for the result of the culture, that takes too long. Broad spectrum antibiotic treatment straight away. Then if we get a culture result later on, we can modify the treatment to make it more specific to the particular etiological organism. So obviously, kill the infection. So treat the infection. Broad spectrum antibiotic. as soon as sputum is taken for culture and sensitivity. The next principle of management is mobilised secretions. Now, we've mentioned the aim, we've talked about prevention of spread, we've said treat the infection. Now it's mobilisation of secretions. And this is what we talked about before. There's an infection here. And the bacteria in an infection, remember, can multiply every 20 minutes. So unless we're getting these bacteria out by getting the secretions out, then the condition's not going to get much better. So we must take whatever steps we can to mobilise secretions and encourage expectoration. And what we're looking at here in this section is how we do that. So mobilisation of secretions, absolutely fundamental management principle. Because remember, a mucus plug can lead to atelectasis or collapse. That means collapse of an area of the lung, as we saw in the example with the segmental pneumonia. So if the mucus becomes very dried out, these are the bronchial passages here, and you get a completely dry mucus plug here, then that can completely block that bronchiole and result in the collapse of the area of lung it would normally supply, atelectasis. So avoid mucus plugging. Keep secretions mobilised and being expectorated. Keep getting them out. Very important to nurse them sitting up, if at all possible. Nurse propped up. Keep the secretions mobilised with chest physiotherapy, if the patients will tolerate it. And if the patients are being given oxygen, make sure it's humidified. Because if it's not humidified, if any gases inhaled are not humidified, they will dry out the airways. Whereas if they're humidified, they'll keep the secretions moist and allow them to be wafted up by the cilia and coughed up. So humidified oxygen if oxygen is required. Frequent positional changes will enlist the help of gravity in draining various parts of the chest. So keep changing the patient's position. And if the patients aren't coughing at least every hour, then tell them to do so, because there may be secretions there to be coughed up. And of course, as always in any nursing management, we need all the help we can get the physiotherapists in. They can help us in this management to keep secretions mobilised. So we've talked about prevention of spread, treat the infection, mobilise secretions. Next point we're going to mention is improvement of the patient's overall condition. The healthier the patient, the more likely it is they're going to recover. So as well as treating the patient specifically for the specific condition, we must promote their health as much as possible. And this involves physical and mental rest. The patient's stressed, they're going to produce more stress hormones, and that in turn can interfere with the immune process. So mental rest is very important. Physical rest is vital. Sick people should take no exercise. Nutrition. Now, of course, the patient might not feel like eating much because they're very ill. But if you think it's necessary, think about concentrates, protein and carbohydrate drinks and things like that. Now, with treatment, the prognosis for pneumonia is really fairly good, so we can reassure the patient and take all measures possible to reduce their levels of anxiety. And as always, involve friends, family, other people that are important to the patient in care. Care should be planned collectively with the patient and with family and significant others. It's not something we impose on patients, it's something we do with them. Plenty of fluids to prevent drying out of secretions. Encourage them to drink 3 to 4 litres a day. And basically keep them comfortable because they're going to be sweating, they're really ill. So change of pyjamas or clothes or whatever they're wearing. and give them a wash when they feel like it to keep them feeling as comfortable as possible. So we've talked about prevention of spread, treat the infection, mobilise the secretions, improvement of overall condition. Let's think of a few things now that can improve patient comfort. Let's think about a few things that can promote patient comfort in general. Well, initially the cough is unproductive, so isn't really doing much good, but it can be painful, so you could give the patient a linctus then. Not that it does much pharmacologically, but you could consider it if it makes the patient feel better in the first, say, day of the condition. But later on the cough becomes productive, and then a linctus would be contraindicated. A linctus suppresses cough, of course. An expectorant encourages cough. So later, productive cough, an expectorant could be given. Don't worry about these cough medicines. They're not pharmacologically very active. They're mostly to make the patient feel a bit better. So if they're not available, don't worry about it. Certainly do not spend money on them if money is short. If money is short, the key thing is the antibiotics, not the cough medicine. The cough medicine is peripheral. The antibiotics are potentially life-saving. Patient's mouth's often a bit dry and crusty and not very nice, so regular mouth care can make the patient feel better. And then if the patient's disorientated or very unwell or delirious or whatever, if they've got reduced cerebral function secondary to cerebral hypoxia, disorientation, whatever, look after them and make sure they don't hurt themselves. Make sure they don't fall out of bed or hurt themselves in any other way. So prevent harm during periods of disorientation, should they occur. So we're talking about management. We've said prevent spread, treat infection, mobilise secretions, improve overall condition, promote patient comfort. We'll now go and look at drug treatment. Perhaps the key aspect of management is antibiotic therapy. If we can give this in results as the result of culture results, great, but if not, we'll treat it anyway, and we start treating it as soon as we can. And one of the key antibiotics here is amoxicillin, if the condition is not too severe. So amoxicillin, relatively cheap, fairly commonly available, usually quite effective. Reasonably high doses of oral amoxicillin. Another drug which may be used is erythromycin. Erythromycin is particularly useful if the etiology is a mycoplasm, in fact. So if people don't know what causes it, sometimes they'll give amoxicillin and erythromycin together to sort of cover both possibilities. But amoxil would be the most common one, amoxicillin, because that would be active against the bacteria. Another one that's sometimes used is flufloxacillin. Flufloxacillin could be used because it's more active against staphylococcal organisms, in fact. And there's a place for the cephalosporins, oral cefalocor, 250 milligrams 8 hourly, and erythromycin 500 milligrams 3 times per day is a standard suggested protocol that you might see in current medical texts. But if the good diagnostic facilities isn't available, then perhaps the best one to go for is the amoxicillin, if you're treating blind, if possible with erythromycin as well. So antibiotic treatment, absolutely vital. If the condition is more severe, then intravenous cefuroxime 1.6 grams 6 hourly and erythromycin is one regime which has been suggested. So we're talking about management. We've done prevention of spread, treat the infection, mobilise secretions, improve overall condition, patient comfort, drug treatment, and finally in this section I want to talk about convalescence. Now, pneumonia is a severe condition. The patient is very ill usually, and after serious illness it can take some weeks to recover. So plenty of time for convalescence needs to be allowed. So let's look at a few principles involved in convalescence. In convalescence, we should gradually, and this is the key word here, gradually increase activity as the patient feels able over several weeks. In fact, even longer if the patient feels the need it. So the patient will need extra rest periods built into their day for some weeks or even some months after the condition. This does not mean to say there's something wrong that it's taking a month or two to get right again. It's just a reflection that it takes time after a serious illness to get better. It's not an instant thing. Bear in mind, patients may have lowered resistance for some time, so we want to be careful they don't get subsequent infections. We need to pay particular attention to nutrition. Plenty of proteins, carbohydrates, vitamins, minerals. And breathing exercises might be recommended. And finally, follow-up. Chest X-ray would usually be performed just to make sure there's no residual problems. So management, remember the principles are prevention of spread, treat the infection, mobilise secretions, improve overall condition, promote patient comfort, drug antibiotic treatment, and convalescence. So we've considered pneumonia in some detail. And most of what I've said about bronchopneumonia, I think you can see that would apply to lobar pneumonia as well, to Lobar pneumonia as well. But let's look at a few specific characteristics now of Lobar pneumonia before we finish this study of pneumonia. So we think about Lobar pneumonia particularly. And first of all, the etiology. Well, nearly always the etiology is the pneumococcus. Over 90% of cases caused by the pneumococcus, proper name for which is Streptococcus pneumoniae. So that's nearly always the etiological organism. It's important to remember that Lobar pneumonia killed thousands of young adults before antibiotics, and indeed is still a very dangerous condition. These days, of course, in the UK anyway, it's treated very early, so very often we don't see these gross cases, fortunately, so frequently. But in developing countries, it's still a common problem. And antibiotics are necessary once it is established. Clinical features. The key thing here is the pain. The parietal pleura is on the outside and the visceral on the inside. And for breathing to take place, the two must move against each other to an extent to allow expansion of the lung. And when they're inflamed, and there's often inflammatory fluids there as well, then it's very, very painful. Any movement of the pleura is very painful. And the pleura will be infected over the affected lobe. So involvement of the pleura over the infected lobe, causing a sharp knife-like pain. They say it's like someone sticking a knife in you. And you take a deep breath in, well, they just couldn't because the pain would stop them. So they tend to breathe shallowly to prevent the pain, tend to guard the area as well. It tends to move less because of the pain. So pain over the affected lobe, generated by the pleura over the affected lobe during respiratory chest movements. Pain in the chest. So sharp knife-like pain on respiration. Normally caused by pneumococcus. Tends not to affect the very young and the very old for some strange reason. I mean, you can get young children and old people with lobar pneumonia, but it's very uncommon. This is nearly always young adults affected by lobar pneumonia. Often rust-coloured sputum, which is purulent. The rust-coloured sputum is very characteristic of pneumococcal infection. Of course, you can get rust-coloured sputum from pneumococcal infection and bronchopneumonia as well. I mean, I'm not saying that rust-coloured sputum is diagnostic of pneumococcus, but it is highly characteristic. purulent, of course, infected. Rapid shallow respirations, especially so in lobar pneumonia because of the pain. The affected side moves less because of the pain, and the muscles round about it tend to splint it to guard the painful area. And of course the infected lobe is consolidated, therefore it's got fluid inside it, therefore it will not sound hollow, it will sound dull to percussion when it's tapped. Treatments, much as we've described already for the treatment of pneumonia, things like amoxicillin and flufloxacillin and cephalosporins may be used. But of course in this pneumonia the patient's got pain, so we don't want to give opiates which might depress the respiratory centre. So a reasonable compromise seems to be to give pethidine. Now pethidine, I'm not saying pethidine does not cause respiratory depression, it does, it can do. But the pain is so bad that pethidine seems a reasonable sort of compromise. You want to get rid of the pain for clinical reasons. I mean, apart from the fact you don't want the patient to be in pain. But if you treat the pain, it will allow greater chest movement, which is good for the recovery, help the patient recover from the condition. So pethidine can be given if intramuscularly, if the chest pain is severe. As we've said, large amounts of inflammatory exudate may completely fill one entire lobe. And this is consolidation, but it's localised consolidation, unlike the patchy diffuse consolidation that we saw in the bronchopneumonia. We did this at the beginning when we looked at the x-rays. The pleural surface of the lobe is also inflamed and becomes covered with a tenacious, shaggy, thick layer of fibrin. The fibrin, of course, part of the inflammatory exudate. Bacteria can also get in, pleurisy, inflammation of the pleura, very painful. So pleural involvement over the cover, over the affected lobe. And this is of course a life-threatening condition. But even without treatment, many patients will recover, and the lung tissue usually recovers with little or no residual damage, although there can be some residual damage, but very often they do recover well. And of course with antibiotics the prognosis should be good. So just a few things that help us to differentiate between the broncho and the lobar pneumonia. Last part I want to do in this section is look at the complications that can occur with pneumonia. These aren't common, most patients recover without them, but it's worth knowing that they exist just in case. So complications of pneumonia. First one to consider is lung abscess. In a lung abscess there's severe localised suppuration, an infected abscess type area, and that can be associated with cavity formation and destruction of the lung tissue. And of course you'll get partial healing round about it and get into an abscess situation that might become chronic. Aspiration and abscess, abscess tends to occur secondary to aspiration. That will be the most common cause of abscess. Lung abscess can also occur secondary to obstruction of the bronchiole, of a bronchiole for whatever reason, part of the bronchial tree. Lung abscess can also occur after septic pneumonia. In lung abscess there's often copious amounts of sputum, and it's foul-smelling anaerobic type sputum from the inside of the abscess where oxygen can't get to. And classically in this you get a swinging fever. As some of the bacteria released into the system, the fever goes up, they're dealt with and the fever goes down again, so you often get fever swings typical of abscesses. So ensure that pneumonia is completely treated before you finish. So lung abscess, one possible complication. Another possible complication, empyema, which means pus in the pleural cavity. This can occur after a ruptured abscess, for example, pus going into the pleura. So often anaerobic organisms causing empyema. And of course this makes the patient ill and they have a high fever. So quite a serious condition, quite a serious complication, this pus in the pleural cavity. Anaerobic organisms, of course, can be necrotizing, very dangerous things to have around. Other possible complications: cardiac failure due to the strain on the heart, endocarditis due to presumably bacterial spread, and meningitis is a rare but documented complication. So we've looked at pneumonia and its management. I would challenge you now to make up a care plan. List the problems that patients can suffer from. List your aim for resolving that problem, your intervention for dealing with that problem, and how you're going to evaluate whether the problem is resolved or not. That's an exercise that you could consider now. But just before I finish, one more thing to say. TB, tuberculosis, of course, is in a sense a form of pneumonia, but the presentation and the treatment are quite different from what we've discussed, so God willing we'll make a separate video looking at tuberculosis specifically. So we've looked at pneumonia. I think you should now try and make a care plan for your management of a patient suffering from pneumonia. I just want to finish this talk off by giving you a few images to think about. I'm just looking here at some normal alveolar tissue that shows the structure of the walls of the alveoli and the air spaces within those walls. Then after that we'll put a slide up of someone who's got consolidation in the case of pneumonia, and we'll see that the alveolar spaces are all filled up. So let's look at the normal alveoli first. So here we see some normal alveoli, magnified, I'm not sure, about 400 times, something like that. And I think you can see the wall of the alveoli around here, in this section. Of course you can't really see the proper shape of them, it's a section. But the very thin, you can see the walls are thin to allow gaseous exchange between the capillaries and things which will be in these walls. And the main thing is that all this here is fresh air. Well, it's alveolar air really, but it's the air sacs. So you can see why the lung is spongy and how the lung inflates in these air sacs. So we see air sacs. The normal alveolar picture and the air inside the alveolar spaces. Now here we're at about the same magnification and we're looking at a similar lung field. And the impression is that the tissue is solid. And remember we said consolidation means to make solid. So this is a consolidated area of lung in the case of pneumonia. But if we actually look more carefully, we can actually delineate here, we can actually see that here we've got the alveoli membrane around there I think, around here. So here's an alveolar membrane, and this is all full of material, but this used to be the airspace. I think around here you can see the alveoli as well. So what we've got, exactly the same as we had on the diagram that we looked at. There's the alveoli. See around there, the membrane. But it's all the alveoli are completely filled with this material, and all the dark staining bits you can see are actually white blood cells. So we've got a consolidated lung, the alveolar spaces are full of fluid and white blood cells. Slightly higher magnification here, I think again you can see the alveolar wall. It is a bit hard to pick it out because the consolidation is really quite complete. The alveolar wall. And of course all this should be air, as we saw in the original shot, but it isn't. It's consolidated with this inflammatory fluid and inflammatory cells. And I think now you can probably start to see that a lot of these cells here are polymorphonucleocytes, the body's white cells that protect against infection. And in still higher magnification, now we can see the alveolar membrane here and all this area. And now I think you can see the nature. These are the nuclei of the polymorphs, the white blood cells. And I think you can see that the space is filled up with these white blood cells, pus cells. And of course, it is all inflammatory fluid as well, meaning this area of the lung consolidated and infected and unable to facilitate gaseous exchange. And now the last two images on this pneumonia talk, then we're finished. This is a macroscopic section of lung with a bronchopneumonia. And I think you can see that there's inflamed red areas virtually all over the place. And there's some pink area. This doesn't look too bad here, for example. This doesn't look too bad. This looks like a normal, healthier pink colour. But you can see the inflamed red areas in different parts of the lung field. So a macroscopic case of bronchopneumonia. Now here we see a lung that's been sliced open down the middle. I think this must be a left lung, it's got two lobes. And the top lobe looks okay. You can see the bronchial spaces quite clearly there, for example. But the bottom lobe, and again you can see the demarcation between the lobes very clearly. And this bottom lobe is consolidated. For example, you can't see where the air passes, maybe a few there, but it's hard to see in this area where the bronchioles are because it's consolidated, be filled with fluid. So a case of left lower lobar pneumonia. One lobe involved, the other lobe not. The lobar type